Okay, so jumping into thorax and abdomen, this is different than the spine chapter because that's going to include our cervical, thoracic, lumbar, sacral, and coccygeal sections. This is just specific to thorax and abdomen itself. Now, again, there are a variety of different conditions that we won't talk about, especially as it relates to some of the organ systems, but the ones that are in the PowerPoint are going to be the most important ones for this unit. So thorax and abdomen, what bones are going to be there? And especially when we're thinking about bones, those are also going to be relevant to the borders of this region. So when we're talking thorax and abdomen, how high, how low do we extend on the body? The ribs, the clavicle, your collarbones, moving all the way back down into the bottom of your ribs. So ribs number 12 will be important. Here we have the sternum or the breastbone in the front and the xiphoid process, which if you've taken a CPR certification class, you may have heard that it's not uncommon for ribs to break during cardiac compressions and especially that xiphoid process. So part of that breastbone, just the very most bottom part, 12 ribs here, but we can further classify them by how much of them actually join to that breastbone itself. So ribs 1 through 7 are referred to as your true ribs, where they will have direct articulation to that sternum. Now, again, what makes your chest have some recoil ability and allow you to breathe, allow you to move, things like that will be this cartilage. So it's not all bone all the way around that chest. That very frontmost segment is going to be cartilage. Terminology wise, when we're talking about the ribs themselves, that'll be cost or costo. So our costal cartilage is again where that bone stops and that cartilage starts. So joining that sternum or that breastbone in the front. Ribs 8 through 12 are false ribs, so either joining that sternum by a lot more cartilage or 11 and 12 not joining that anterior portion of the body at all, basically just hanging out more on the posterior side and not attaching to that breastbone at all. In the posterior side, again, we have our scapula or our shoulder blade and the glenoid fossa, which especially as we were talking about the shoulder joint, the true shoulder joint ball and socket, that's going to be that socket where that shoulder will form. Muscles, what's acting on the trunk and thorax? And again, there are several, not only when it comes to voluntary contractions, but also involuntary ones, especially when we think about the muscles involved in respiration or breathing. So the ones that we will spend the most time on, intercostal muscles, just meaning between, cost, again, the ribs. So intercostal muscles between each of these ribs. They will act basically together anytime that the chest is open, your arms are above your head, you have some rotation to it. Those intercostal muscles will be functioning. And again, they're respiratory muscles as well. So even though we are not voluntarily asking them to contract, they're still contracting to allow us to breathe and move throughout the day. Other muscles, again, there are several layers of the abdomen, especially transverse abdominis, your internal and external obliques, rectus abdominis. So again, thinking terminology wise, rect meaning straight. So straight down the abdomen, right, will be these muscles here. So the primary muscles involved in lumbar flexion or kind of moving forward. If you're going to stand and touch your toes, that's the rectus abdominis function. Umbilicus, fancy word for just your belly button. We'll talk about McBurney's point a little bit later. It's not one super specific one spot, but it's about halfway to 2/3 between, again, your ASIS or that kind of front bony part of your hip and your belly button. That halfway to 2/3 area here is where you'll have a lot of pinpoint pain, tenderness, localized swelling, things like that if you have acute appendicitis. So if you have pain smack dab there, only on that right side, pretty good chance that you'll have to get a surgery later that day for getting your appendix removed. Thinking about just location of different things, anytime you're talking about the abdomen, usually you'll hear different segments of it referred to as quadrants. So pretty simple, upper, left, lower, right. So this is again on the patient. So if I'm looking at this person, if this is my right, but it's actually their left. So this would be the upper left quadrant, even though it's on my right, if I'm looking directly at it. And then the lower right and left quadrant, upper right and left quadrant. I'm not going to be really picky about knowing what's in each each one of these quadrants specifically, but just realize in some situations where you have upper left quadrant pain, lower right quadrant pain, it's going to be basically anything in these borders. Injury prevention. Now, when we think about the thorax and the abdomen specifically, we don't usually think about a lot of orthopedic injuries. No one is usually going to the doctor for abdominal strains, like they might for sprained ankles and things like that. But they definitely do still happen. Sometimes it could be because of trauma, but then we can also have some more chronic, more overuse type conditions also. So when it comes to injury prevention, we can definitely do a lot of work in preventing the acute injury, usually in regards to padding, bracing, strengthening, things like that, making the body more strong so the chance of injury happening will decrease. But then we also have a lot of things that are caused by illnesses, disease, and other pathologies that are a little bit harder to control by one specific means, other than just maintaining good hygiene habits, getting vaccinated, not overdoing it or doing anything crazy like that. So most of this stuff, again, talking about trauma here, we can classify all of our abdominal organs by either being hollow or solid. And that's exactly like what it sounds like. Hollow organs can become full and then empty. Solid organs, even if you were to chop them in half, they're basically still full left and right sides. So to prevent injury to hollow organs, it's going to be the recommendation that you empty them prior to competition. Now, what organs are we talking about here? Things like the bowel and the bladder. So we can, again, have those be full or empty. If they're empty, they take up much less space versus if they're full. So if they're taking up less space within the abdomen and there's a trauma or an impact to it, it's going to decrease the likelihood that it can get injured just because it's taking up less space. So go potty before taking the field, and it might decrease the risk of injuring just some of those organs. Now, it's not going to decrease you taking the blow, it's just going to decrease the chance that an injury could result in that, specifically to some of those organs. Especially thinking about the sport, position, event, things like that. Good form, good physical conditioning, proper technique is definitely vital to learn this. So how to tackle, when to tackle, location of where your helmet is, your shoulder pads, how things fit properly should definitely be something addressed that early on in that sport, just so you can learn good habits and then perfect them later on. So when it comes to assessing the abdomen and thorax, and again, a lot of those injuries, we have to think about, because it is a lot of your visceral organ systems, kidneys, liver, spleen, appendix, lungs, heart, things like that, a lot of the acute injuries could result in something more life-threatening. So if there is internal bleeding, first we have to be able to understand what the signs and symptoms would look like if that person did have those conditions, and always think about the most worst case scenario first. So things that would result in sudden death, issues with airway, breathing, circulation, severe bleeding, shock, those things need addressed first. So that's all of our primary survey. Even if they're walking, talking, and appear fine, that primary survey still happens, even though it might just be more of a mental check. Yep, they're okay. Let's move on now to our secondary evaluation, looking for the more orthopedic things and things like that. So how do we find that there are issues in that primary survey? Again, those life-threatening situations, a lot of our vital signs will tell us, again, how that person is doing. As we have internal bleeding, or in some instances of shock, we can see a lot of variation when it comes to our vital signs. So taking things like temperature, respiratory rate, pulse, blood pressure, even listening to lung sounds or abdominal sounds, heart sounds, anteriorly, posteriorly, left, right sides, it's all going to be important, especially to take those early on and then track any changes. So if something is a little funky, note that, and then 15-20 minutes later, if you reevaluate, you can track those changes and see if their blood pressure has just plummeted. If it was a pretty normal level at first and now their systolic pressure is just in the tank, they've got a really low blood pressure, we're thinking, well, what's going on now to make the heart kind of wimpy when it goes to actually pump? It could be because of some kind of shock, internal bleeding, something that could be one of those life-threatening conditions. So always important to rule those ones out first, just because time is of the essence. If we don't use our time wisely and we focus too much on the, what happened, where's your pain, 1 to 10, how's it hurt, is it sharp, dull, icky, throbby? If we focus too much on playing 20 questions with them, we're really missing a vital window that might tell us if we need to call 911 right away, if we need to get the ambulance on site, and how to handle that acute care of those injuries or conditions. So important history, observation, palpation, special test. A lot of this very similar to all the other injuries that we've talked about. So those same basic history questions. When did it start? How long does it last? Did you hear or feel anything pop? But then also, if it's something where it wasn't as acute, so it wasn't something that you saw just like right now. If it happened yesterday, it happened 2 weeks ago. There's some additional history questions that might factor in, especially as it relates to a lot of the function of those internal organs. So is it painful to breathe? Do you have difficulty breathing? If you're dizzy, well, maybe that's because either the blood loss or now issues as it relates to oxygen saturation. If you can't breathe because there's an issue in your lungs, or even if there's fluid around it and it can't function properly, well, that's one of those vital signs that might also be inhibited, having those O2 sats kind of going crazy. And again, there are a million questions in addition to this list, but thinking back to, again, some of those more body function type stuff, do you feel hot or cold, like just really flushed or freezing cold? Could be an indication that shock is setting in. Any changes in bowel or bladder? So does it hurt to go to the bathroom? Do you see any weird color changes? Are you someone that typically goes a couple times a day and now you're going a dozen times a day, right? Any change other than the norm is important to know as it relates to how those other body functions are happening. How long has it been since you last ate, especially if this becomes a surgical situation now? They're going to recommend obviously fasting before the surgery, just so when they intubate you and give you all the meds to sedate you, there's less of a chance that so you might regurgitate and then have some issues with choking on that. But I mean, if now your tummy is so upset that you can't eat, or you have only eaten just little handfuls of food because you're nauseous and dizzy, definitely things that are going to affect your athletic performance. Any family history of things, especially abdominal problems. As we get into late teens, early 20s, sometimes this is going to be important as it relates to some diagnostic criteria. So if you're going to be diagnosed with type 1 diabetes, so the kind that you're born with, diagnostically you have to you can only get that diagnosed before age 35. After that, it's diagnostically not type 1 diabetes. Type 2, again, is going to be something that you're not necessarily born with, but that develops later in life. Typically, that's associated with older people, but now we're seeing this happen in a lot of our younger demographics, especially those that are overweight or obese and have a lot of poor lifestyle factors. So any family history is going to be important to know, even things like Crohn's disease, or just lifestyle stuff. So if you're eating a diet high in saturated fats or trans fats or salt or sugar or something like that, it might make you, again, more likely to develop some of these more long-term conditions. There's some cardiac issues that, again, can have some genetic roots to it. So even if they don't necessarily know if they have whatever condition, if they know, well, you know, dad had some heart issues that kind of started when he was a little bit younger, or, you know, mom had whatever condition and her mom did too, well, it might be a little bit more likely now that you may also have that genetically inherited condition. Pain during urination or blood in the urine. It's kind of gross to think about, but it is important to ask if they have seen any changes as it relates to bowel and bladder habits, just because you can tell a lot about what's going on internally just by looking at these things. So even though it's uncomfortable to talk about, they don't have to necessarily tell you, but just make sure that a healthcare provider is aware of any changes that have happened, especially in more recent times. And if they knew the onset of that, what caused that, or directly after what happened led to some of these disturbances. Observation. So when we're looking at them, how are they breathing? Are they kind of hunched over? Do they have a nice big open chest? Are they leaning maybe to one side and especially trying to almost splint it with that other arm, keeping it close to their torso? When they are breathing, is there symmetry in motion? Does each side of the chest rise and fall at the same time? Or maybe is one side oxygenating while the other is not? That could be a sign of a collapsed lung. Sometimes you may, if you watch like Chicago Med or Grey's Anatomy or ER dramas, they might talk about, especially if the windpipe or some of the vasculature in the neck is kind of moved to one side. Again, it could indicate several different things. Not something that will be super relevant to this class, but again, when you're making observations, especially in regards to life-threatening conditions, there's a lot of stuff that you might note. Body position will be one. If they've got the inability to stand upright because it puts all those abdominal muscles on a stretch, maybe that's a more comfortable position for them to kind of be hunkered over. Just something to know. If they got the wind knocked out of them, what's their breathing like now? Are they hyperventilating, breathing too quickly, and now maybe they're not pulling in as much oxygen just because we do have really short, steep breaths, or are they unwilling to take long, deep breaths? Is that really painful? A lot of things that we can observe for. As far as physical observations, looking around for any type of discoloration, swelling, bleeding. Now, external bleeding is going to be when we actually see the blood coming from the person. That's going to be a little bit more obvious. But as far as internal bleeding, there's not often a really great way to tell if it's bleeding, and definitely not where that bleeding is coming from. But there are a couple things that we might see. So one would be if you have any type of swelling or discoloration right around the belly button, just showing that there's some type of bleeding within the abdomen. But if it's around the posterior low back in your flank region where your kidneys are, right, this might show that there's swelling outside of that abdominal cavity. So there are kind of some separations internally within the body. Also, we have to think about any type of belly trauma. Think like car accidents. Your seatbelt kind of checks you. It might kind of knock the wind out of you in the short term. Not uncommon to see bruise patterns across the chest or right on the belly where a seatbelt was. And then noting to see if that belly continues to swell over time. So it's just getting larger, right? So this is going to say that there's maybe some swelling or some bleeding or just some type of free fluid within that abdomen. You used to have a nice flat belly and now it's just going to continuing to grow. That's going to be showing that there is something going on there that's definitely going to warrant further examination. Monitoring their blood pressure when you're poking around or palpating. Do they have any pain on those ribs themselves, more on the costal cartilage, between those ribs? It could be maybe on the muscles. When we're palpating the abdomen, this one's kind of tricky. I'm going to jump ahead real quick and show that the best way to do this is laying down. And honestly, if this clinician had the guy's knees flexed and his hips flexed, it would relax the muscles of his abdomen. So if you're trying to really poke on someone, especially that's having pain, this is not going to be a comfortable position, especially when you're laying down. Everything is on a stretch. So if you have them bend their knees and keep their feet flat on the table, but just bend these knees up, you're going to be able to move some of those organs around a little bit better and have a better idea about where some of that tenderness is. We also have to think that as far as locations of pain or tenderness within the body, we have something that's referred to as referred pain patterns. Now, overall, this is something that's not completely well understood, but we do know that it exists. So there are several different referred pain patterns within the body, just saying that even though the organ might be in one specific location, it might refer pain to a different site in the body. So if someone has shoulder pain, is it because they actually have an issue with their shoulder, or from the abdominal region, is that just a referred pain pattern for liver and gallbladder type issues? So if there's no mechanism of a shoulder type injury, but their shoulder hurts and maybe they have pain in several different locations, it could again be an indication that that's a referred pain pattern. Now, in most cases, the referred pain is just a wider area from where that organ actually stems. Some scientists think that it's because there are some nerves that are shared between that structure and other areas of the body why these referred pain patterns happen. A common one that you've probably heard of is if someone's having if someone's having a heart attack, they might have pain or weakness or discomfort in their entire left shoulder, arm, sometimes the jaw or the neck. Again, if you're thinking that the heart is kind of right here, not too much of a far stretch to think that those areas would also be injured. So are they having a heart attack, or do they have an arm, a shoulder, a neck issue as well? So just kind of be aware that these exist. It's not necessarily something to where we're relying heavily on these referred pain patterns, but just being aware that they do exist. Okay, so talking about some of our more orthopedic conditions. A rib contusion, we already know, fancy name for a bruise is a contusion. How are you getting any type of bruise? Well, that's going to be direct trauma. So someone's going to hit you, you're going to fall onto something. The ribs having that cartilage and the bone, makes them a little bit pliable and movable, but it also doesn't really do a whole lot in protecting those ribs, just because, again, even a larger person, you can still probably feel each of those ribs discriminately. So at each level, we can feel all those different ribs. There's not really a lot of meat there to protect them because those muscles will be in between each of those rib layers. So a blow to the rib cage can happen in several different sports, especially when you're thinking about more of the adolescent population that have maybe slower reflexes and can't move back from the plate to protect themselves. They might be a little bit more exposed, especially when they're at bat. So we have that whole side just opened up. If they were to take a wild pitch and they can't move out of the way fast enough, they might take some of that force to the ribs themselves. Now, as far as what can happen if you do take a blow to the chest, several different things. On a minor level, you can have a rib contusion, but it can also lead to a rib fracture. We can have a costal chondritis, so rib cartilage inflammation, where it just hurts every time the chest expands from normal breathing. There can be some cardiac issues that can stem from this that we'll talk about a little bit later. But to just treat the bruise itself, some rice, some ibuprofen, a little bit of compression, decreasing activity will be helpful until the bleeding stops and that bruise kind of subsides. But in the short term, a little bit of compression will feel good. You just have to make sure it's not compressed so much that now the chest can't expand like it should. Make sure that they're able to breathe. Now, if we're squeezing the crap out of them and they're not able to breathe properly, that's going to cause more issues. So just be smart when it comes to some of the treatment of this. No one will ever be mad at you if you tell an athlete that they need to go to the doctor, go to the hospital, go see a specialist, something like that. If they understand that it's because you have their health and safety at the forefront, you're only being beneficial in that case. It's not something where a liability issue will stem from this because you said, hey, I'm kind of concerned that you're having some breathing issues after you've taken a blow to the chest. Might be a good idea to go get this checked out. You've released that liability on yourself. So rib fracture is something, again, can also happen with that direct trauma to the ribs. As far as which ones are going to be fractured, we have to think about the false ribs and the floating ribs have more of that cartilage. So it's going to be more likely to have a rib fracture above ribs 7 and up. Ribs 1 and 2 are pretty well protected deep to the clavicle or the collarbone. So these ones are pretty well protected, but as we get a little bit lower, they are a little bit more exposed. So if someone does break a rib, everything will be painful. Getting dressed, taking deep breaths, climbing stairs, anytime you're doing something where your breathing and your heart rate might increase and cause that chest to move a little bit more will be extremely painful. In older people, especially, you hear about rib fracture sometimes with really violent coughing fits, sneezing fits, if they have pneumonia and a lot of fluid has accumulated around the lungs themselves. When they try to forcefully cough it out, sometimes their bones can be so brittle that it can actually cause them to break. So something that oftentimes is helpful for rib fractures, obviously getting an x-ray first so you have a good idea where the damage lies. In some cases, if a rib does break, it can dislocate posteriorly and cause some issues with collapsed lungs, punctured lungs, things like that. For the most part, just a little bit of support, just with compression wraps, will be helpful. But you also have to think that if they do have a rib fracture and anytime the chest opens will be painful, if they're trying to put this wrap on themselves, they're going to have to lift the arm to be able to wrap it across. So they might need a lot of help even getting in and out of their brace. It's something that should be worn for most of the day, obviously taking it off to shower. So they might, again, need some help putting it on, taking it off, and it might be a little bit uncomfortable, especially as it starts to kind of move and roll up if it is an ace wrap. So we do have some special braces that exist. I'll show you here in a sec. Here we have, again, a baseball picture of a rib fracture. You have to look kind of closely here to see these issues, but here we have that tiny little fracture line here, and then we again see fractures on either one of these two sides. So these again are some of those lower ribs that are being injured, ribs 7 and up, a little bit more likely to have injury. And as far as baseball, you're not really wearing a lot of protection. So if you do take a blow to the side, there's not even any padding really to absorb some of that force that can lead to not only rib contusions, but rib fractures. Costal cartilage injury, again, sometimes these might be kind of lumped in or even misdiagnosed sometimes as a rib fracture. It can still happen from a direct blow, but here it's not the bone that's actually injured, but the cartilage itself. So pain with deep breathing, pain with motion, again, any time that you're having that chest open could be causing a little bit more irritation. If you've been sick for a while and again, you're just forcefully coughing, it could cause some irritation at the junction where the bone and the cartilage meet, or where the cartilage meets the bone of the sternum or the breastbone. Treatment is about the same. Rest, immobilization, a little bit of compression might be helpful. When you think about breathing issues in the lungs and our rice, police treatment, sometimes you have to be mindful about putting ice on because it can actually cause some shortness in breath sometimes. If you think about when you're outside and you're walking and the air is cold and it kind of hurts to breathe in, you're not taking nice full breaths. So ice in some cases might be helpful, or just the cold could actually make it more difficult now for that athlete to breathe. So here, a picture again of our costal cartilage injury, costal cartilage separation. Here, it's not inflamed, it's actually started to separate or pull away. So we do have these are called rib belts. So they're basically the same, men's versus women's. Women's will have a cutout on the front just to accommodate for a larger breast or chest tissue, but it's between 6 and 8 inches wide that just kind of wraps right around that most injured point of the body. Its job is more compression and less on like the foamy padding of it. This isn't something that's going to be worn much after that injury has healed. Again, it is a little foamy, but its job is not padding. It's mostly that compression. So if they have to, again, open their arms up to get that wrapped around their body, it might be painful to get in that position. So just let them know, hey, I'm going to put this on. Don't be surprised if you need help from your roommate or someone like that later tonight to take this off. Now, unfortunately, because the compression feels good, when you remove it, oftentimes that's when pain will increase. Again, not uncommon that that happens. And after you put compression back on it, it might feel better, again, because that chest is not opening as hard to cause more inflammation. But just let them be aware of that before you put this rib belt on. If you don't have something like this, you could also essentially make your own with just an ACE wrap, but just be mindful, especially people that have more of that hourglass shape. We're thinking that it's going to kind of, the wrap will gravitate more towards that center and will kind of just roll up. So when you're wrapping it, again, don't think of it as a binder of sorts. Just make sure you kind of spread it out evenly across that way, and wrap it firmly and securely in place to where it'll help with compression. But again, once it starts to roll up, you might need to take it off and then reapply later on. Okay, looking at intercostal muscle injury. So again, the muscles between each of those ribs, between each of those rib layers, you will have different muscles. Most of them are going to be postural support and respiratory muscles, so the ones that actually contract to allow the chest to open while you're breathing. But they're also going to be a little bit more vulnerable to strains, especially when that chest is really open. So think like volleyball, your arms are always above your head, especially if now you rotate and we've opened up that space between each rib. Well, what's there to actually open up with it? And that will be the intercostal muscles. So especially with a lot of active motions where we have to cause movement and those muscles have to contract to turn us in either direction, that'll cause a lot of pain. And then deep breathing, anything forceful, coughing, sneezing, even in some cases, just clearing your throat really hard might cause that rib cage and that chest to become a little bit more irritated and painful. So especially with twisting, you see again intercostal injuries a lot with volleyball, just because that chest is already open and there is some rotation involved. Not saying it couldn't happen with other sports though, but essentially you're treating it the same way, just because how those muscles will attach to the bone and the cartilage itself. It'll also cause some irritation at those unions. So a little bit of compression, maybe some ice. Unfortunately, sometimes you'll need some kind of heavy hitting pain meds to help with this, just because these muscles are basically always active if they are helping in inspiration throughout the respiratory process. So in some cases, an athlete might be given muscle relaxers or something else pain-wise, just to help get them comfortable. A little bit of rest will be helpful, and it might take a while to come back to full participation status, just because this isn't something that you can completely rest away. That chest cavity is always moving every time you move, stand up, roll over in bed, things like that. Sleeping might be kind of uncomfortable for them. So that's another time where some of those more heavy hitter meds could be beneficial. Okay, so that's it for basically the ribs themselves. Now we have to think about how those ribs are affected throughout that trauma process that could kind of by secondary nature affect the lungs themselves. So there are three kind of conditions that we'll talk about with the lungs. They're all very similar. It just depends on a couple of different key terms. So I'm actually going to start at the bottom of this list. Traumatic asphyxia, this is going to be any type of violent blow to the chest or the rib cage will cause a temporary cessation or stoppage of breathing. Similar to if you get the wind knocked out of you and you just can't breathe for a couple seconds, traumatic asphyxia, you'll be able to breathe again later on, but it's just a really transient paralysis where you're just not breathing for a couple seconds. Usually you calm yourself and you kind of get back in it and you're ready to go. If the breathing never resumes, that is going to be cause for medical attention. But in the short term, the breathing should come back. Now, the other three are very similar again in what's happening. It's just the difference between if air or if blood is filling up in the space around the tissues. So I'm going to jump to the next slide just to show you these pictures and then kind of describe those. So we have a pneumothorax, a tension pneumothorax, and a hemothorax. So anything pneum or pneumo refers to air and air movement. So if you have a pneumatic brace, it fills with air. Anything heme refers to blood and iron. So hemothorax is going to be blood, pneumothorax is going to be air. Now, when you think about air in the chest, you're maybe thinking, well, yeah, air in the chest, that's what my lungs do, move air. Well, this is talking about the actual chest cavity, not the individual lungs themselves. So the lungs do hold air and inflate and deflate when you breathe, but I'm talking in the space around the lungs. So when the lung properly inflates, it should fill most of that chest cavity. In instances of pneumothorax and hemothorax, kind of that void or that space around that is going to be filled with either air or blood. Now, where does that air come from? That's going to be the difference between a pneumothorax and a tension pneumothorax. Now, kind of worst case scenario, you can have a tension hemopneumothorax where you have air and blood and a penetrating chest wound that causes that. So with a tension pneumo, you've got an opening in that chest cavity itself by either trauma, getting stabbed, getting shot, getting something where there's now an external hole in the actual chest, and now air from the outside can get pulled in. Now, when you think about how the lungs move during normal respiration, we also have to kind of think about the treatment as it relates to that lung itself. I think I have a slide. No. There's what's called a three-sided patch that could work also in some of the treatment of this. So how a three-sided patch would work, this is an envelope, this is not one of it, but especially in like trauma situations, we have to think about when we breathe in and then when we breathe out, what's happening to that space with outside of our lungs. So if we have a patch on three sides, when we breathe air in, this will suck into the chest itself. So if I'm getting edited out here. Oops. Well, okay. So if I breathe air in, this will basically suck against the chest wall, but it's only closed on three sides. So on this other side, when I breathe air out, air can escape out of that fourth side that is open, but every time I breathe back in, it won't allow new air from that outside to get into that chest cavity. So a three-sided patch in a trauma type situation is going to be something that's definitely going to help to limit the amount of air from the outside entering that chest space. Now, three-sided patches are something that, especially in military settings, a lot of your medics or even a lot of just the soldiers in general will carry with them, because if someone goes down beside them, it's your duty now to act in that case to hopefully have better outcomes for them. So the air is coming from the outside of the body with a tension pneumo, but with just a regular pneumothorax without the tension aspect of it. The air is coming from the rupture of those little air sacs within the lungs themselves. So if we think that there's a pressure difference inside the lung and the chest cavity itself, that's where the treatment comes in. So what you can do in the short term is just try to keep them as stable as possible, monitor their vitals if you can, but make sure that they do get to the hospital ASAP. So what the docs are going to do is try to equalize that pressure inside and outside that chest cavity by applying, my next slide, um, what's called a chest tube. And it's literally exactly that. It's a large plasticky type tube that they will actually feed in between those ribs. So they'll cut a hole in you and stick this tube in, and you can actually hear the air almost hiss as it escapes from that chest itself. Now, every time you breathe in and extra air from the outside gets into that lung, it limits its ability to fill with air when you breathe, right? So if we decrease the pressure, now it allows the lung to re-inflate, and now you can breathe properly. Obviously, this is not a long-term solution, though. So after they have equalized the pressure and that lung has reinflated, then there might be some more surgical interventions necessary. In the case of a hemothorax, where there's blood now trapped within this chest cavity, once they insert that chest tube, that blood will run out, those pressures will equalize, that lung will reinflate, and breathing should come back to normal. As far as reasons that this happens, again, it can be caused from trauma, but if we're thinking about the rupture of the tiny air sacs, the alveoli within the lung itself, there's some training patterns and techniques that might actually cause this to happen. So I'm not sure of the exact name for them. They're sometimes like altitude training masks, but really how it works is that it goes across your face and it limits your ability to breathe in air. People will think that if I just train with this on, now when I go to a higher altitude, it simulates a decrease in the oxygen availability. I won't have to reacclimate to that condition. I'll basically be already set, ready to go. That's not quite how it works though, because if you're limiting your body's own ability to pull in air, when those air sacs try to fill, they are trying to pull in air and just there's nothing coming in, and they ended up rupturing. So though there used to be a guy on campus, you could hear him before you would see him, usually running up the hill from the rec center, had one of those big masks on. And again, he's trying to pull air in, but it's limiting his ability to actually do that. There's also some information that people that are maybe recreationally trying to forcefully suck in air through a small instrument might have some of these pneumothorax type conditions. So especially as you're forcefully trying to suck in over something small, it's going to force those to work a little bit harder.